Well, good evening, everyone. It's so nice to see so many of you here. This is genuinely one of our favourite venues, and I'm not just saying that because we're here at the Lanesborough, and it's always such a wonderful audience to have in attendance. So a big thank you for joining us here. For anyone I've not yet met, I'm Francesca Oakeyman-White, and I'm the founder of the Beauty Triangle. Now, we're here this evening to talk about building strong foundations. After all, I think we can all agree that as humans, we're living longer, we're achieving more, but we're also coming up against the ravages of modern lifestyle, external stress, hormones, just the grind of daily life that bears us down. Which leads to the question, how can we best prepare for the future whilst also building a more resilient face and body? Now, when we launched the Beauty Triangle 5 years ago now, it was very much with the philosophy to educate and empower audiences on all aspects of their health and well-being, and critically always from a holistic standpoint. But it was also to have the conversations that no one was having, and to also host them in collaboration with the most trusted expert voices in the world of wellness, so that consumers can make safer, better informed decisions that are ultimately right for them. On that note, it brings me to our amazing panelists who are joining us here tonight. We're joined by consultant plastic surgeon and Barb's Vice President, Miss Nora Nugent. We're also joined by vascular surgeon and founder of the Whiteley Clinic, Mark Whiteley. And finally, we're joined by the resident osteopath, acupuncturist and back care specialist here at the Lanesborough, Garry Trainer. And really they're here to explore how we can refresh our faces, fine-tune our physiques, enhance our posture and even eliminate pain, which I feel like is going to be a huge conversation when we finally get to you, Garry. Just a few quick things before we start. You'll have found a programme hopefully on your seats. You'll find information on all of tonight's speakers on there. You'll also find a referral card. So if you'd like us to connect you with anyone that you hear speak here tonight, you can just leave your email address, tick the box, and we will do the rest. There's also time for an audience Q&A at the very end. So if you do have any questions, feel free to ask away once we're finished with the main discussion. And then finally, we have an incredible goodie bag for everyone here with some really brilliant products from Mida Beauty and also Ultrient. So please don't leave without picking one of those up. Okay, no more from me, because I feel like I always rattle on at the beginning of these things, trying to set the scene. I'm going to pass over to our speakers. They're going to say a quick hello, and then we're going to get started with the main conversation. So, Nora, over to you.
Thank you, Francesca, and it's a pleasure to be here. So I'm Nora Nugent. I'm a consultant plastic surgeon based in Purity Bridge Clinic in Kent. I'm in full-time private practice with a focus on aesthetic surgery, and I particularly do a lot of face and breast and labiaplasty surgery, but also some body contouring. What I try to convey to my patients is the benefits of the surgery, because a lot of these surgeries on the surface are about appearance, but actually come with significant physiological benefits as well. So it's to look at the whole picture and then plan accordingly and choose what's the best option to go forward for me.
Thank you, Nora.
Hello, I'm Mark Whiteley. I'm a consultant, originally vascular surgeon. I'm now a consultant venous surgeon. I specialise only in veins because it's something that virtually nobody else looks at. I'm one of the rare beasts that I set up a clinic, and then we put all of our money back into research. So we produce some of the most, I wouldn't say most, but an awful lot of the original research from the UK, despite being a private clinic. We unfortunately don't get any grants because we're private, and I can't sit on nice guidelines or anything, but so I just chip away at the sides by writing books, writing articles, going around the world and lecturing on the science of venous pathophysiology, and trying to get people to understand it's not just varicose veins in the legs, it's your systemic venous circulation, and every part of your body is affected by your veins. So I'll just hand you on.
Thank you, Mark.
Good evening. Garry Trainer is my name. I'm from New Zealand originally. I had a very bad rugby injury when I was 17 and ended up in a spinal unit. Had spinal surgery twice. Was told I was the luckiest person in the ward because I was the only one that still had feeling in their legs. Everyone else in the ward was either quadriplegic or paraplegic, so I was the lucky one. And then I went pursuing all different sorts of therapies to see if I could get some relief. And it was when I came across acupuncture that it knocked my socks off. And I was left not believing in acupuncture. I knew it worked, and I felt at that point that I wanted to learn more about it and also help promote it. So that's what I've been doing, and in between times I've been trained as an osteopath and as a masseur, so I combine massage, acupuncture and osteopathy together, so I can get to the musculoskeletal and the nervous system all at the same time, so you can adapt your treatment to what's presenting to you. So if it's acute and you can hardly touch people, they can barely move, there's techniques we can use for those, and then for the chronic sufferer, and then we can get them exercises, we can get them all sorts of things. So basically back pain is what I specialise in because I know it well. After having my spinal surgery, they said that I would suffer a bad back all my life, and I have. So I can relate to it very well. But as I say, I have found incredible relief, and have found that these age-old treatments, both acupuncture, massage, and osteopathy are age-old. I like to utilise those, but at the same time, I've got even scans and blood tests, and I train as a medical nurse as well, so I'm very medically orientated in my practice.
Thank you so much, Garry. I think it's going to be fascinating to hear how the conversation unfolds from, like you say, the age-old therapies to also the things that are high-tech and modern and forward-facing as well. But we're going to get started with Miss Nora Nugent. Nora's already introduced herself to you, but from my perspective, I always find Nora to be a real voice of reason and clarity, I suppose, in the very sort of sometimes sensationalised world of cosmetic surgery. And she's fast becoming known for her very restorative surgeries for both the face and body. So Nora, I'm interested to know, because you obviously see patients at all ages and stages of life, but what is it exactly that is leading to accelerated facial aging right now amongst us?
So there are a couple of things. As has always been the case, menopause changes metabolism, menopause affects hormone levels, which affects skin, and whatever age that happens at, aging is happening concurrently. But one of the new things we're seeing is the effect of rapid weight loss in patients, and it might be surgical after surgery, or it might be after the new weight loss medications. And both of these things are very positive because they bring a lot of health benefits, reducing heart and cardiovascular diabetic risks, but they do come with a sudden loss of volume in the face, and that comes with a sudden or relatively sudden sagging of skin as well. So it brings quite a few people my way.
I can imagine, and interesting because you said the word sudden. I feel like whenever we talk about facial aging, we often talk about this sort of falling off a cliff. And I'm really pleased that you brought up the sort of modern weight loss medications, because I think you're right, menopause, perimenopause, we often talk about grief, we talk about illness, bereavement.
Stress, illness, life events, it all impacts.
But what are you finding from your perspective as a surgeon? What are the things that you then need to be doing almost to help those patients who have experienced the very rapid weight loss? I mean, it seems like such a cruel irony that you can finally fit back into the clothes that you want to wear, sort of perhaps after struggling at sort of menopausal ages, sort of with excess weight, but then you lose it from your face.
Yeah, and I think the reality is everything is a compromise. You gain on one side and you lose on the other. You gain the health benefits of weight loss, you gain some of the mobility aspects and musculoskeletal benefits and cardiovascular benefits, but any sudden weight loss for any reason, the skin doesn't and the tissues don't really have time to adapt properly, and there is a limit to how much they can adapt anyway, and this is more than a few pounds or half a stone here or there. This is significant weight loss.
Yeah.
So it is a bit unfair. And the key things are timing and nutrition. Timing has to be right. If someone's still actively losing weight, it's the wrong time, because I lift and tighten for how someone is at the time of surgery. They lose 10 kilos more and they're not back to square one, but they might be back to see me again, and it's disappointing. You invest a lot in this sort of surgery. You want it to last. And nutrition as well. You use extra calories when you're healing, so you should not be actively losing weight for healing purposes either. So it's all about timing, and surgery is actually more predictable than the weight loss medications. They are not around as long, and some people are staying on them for quite a long time, but we're still not sure whether some patients are going to stay on them lifelong or when they're going to come off. So it's getting to a steady weight is working out, are there likely to be future changes, and then timing my intervention at the best possible time.
You're so sensible and pragmatic. I always love the way you answer these questions. And I think it's interesting because when we look at how the face ages as well, we obviously have the skin, we have the tissues, the fat, the muscles, and we have the bone as well. And we know in sort of the menopausal age that we start to lose a lot of estrogen, and therefore, we start to experience things like osteoporosis. So is that sort of also contributing to this bigger picture of the facial aging we're talking about?
So the bone does get thinner, but it also gets smaller in the face. And it depends, again, it's down to variations in human anatomy to start off with. When I say favourable anatomy, it's favourable for some aspect and not for another. But some people naturally have smaller facial structures, so if they lose volume, the impact is greater because it's a higher percentage of the volume, or it has greater impact. But it is all layers. It's skin, it's the fatty tissue under the skin, it's the support layer under that, which is the SMAS in the face, the platysma muscle in the neck, and then it's the bone shrinking as well. And what that can also do is bring to light structures like the salivary glands that were hidden in the past because
they were sort of hidden under
exactly.
that sort of nice
the
blanket, that
thin.
cushioning. Yes, exactly. Everything gets thinner in some places anyway. And interesting, because obviously I was going to ask you about how you've seen cosmetic surgery evolve since you've started practicing, and I actually think this whole awareness of even how the face ages and those different levels and the compartments and actually how you go about addressing that must probably come into action.
Yes, and it is evolving all the time. Even anatomy, you think all the structures have been defined and delineated. Even now, there are still new aspects being discovered, like how ligaments interact, or how that they can be in small ways more extensive than previously thought. So things do evolve. You have to stay up to date. And while we go by basic principles for plastic surgery, it has to be adapted to the individual as well. Yeah. And all face, breast, body surgery is all evolving, but specifically for facial surgery, it's understanding the layers that you have to treat. It's the timing, as I said again. It's understanding what complements the surgery. For example, good skin care. If you have better skin, you get a better result. There are complementary therapies as well.
Exactly.
So it's tying it all in together.
And what about the sort of long-term effect that we're trying to achieve? Because I feel like particularly when we talk about things like facelifts, everyone is terrified of this sort of wind tunnel, pull tight look.
Those are the ones you see. You don't see
sadly, they're the bad examples. Yeah, they always say the best surgery sat across from you on the train or on the bus, don't they?
It's very true. You shouldn't know someone has had something done. They should look good or better or refreshed, but they shouldn't look like they've had something done. And so when we talk, face and neck lip surgery is becoming quite extensive. You can have very small surgery or actually quite significant all day long surgery. But it's not about overdoing any one area. It's about tying everything in together. And the more extensive surgery is about covering a wider area. So for example, eyebrows, eyelids, face, neck, it all matches and is in harmony. It's not about overdoing any single area. The first couple of weeks after surgery, don't panic, it will look overdone. There's always swelling, things have to soften out. But the long-term result should not look like you've had any surgery at all. You should just look better or fresher or less tired. It shouldn't actually look like you've had any surgery.
And would you say that people are actually embarking upon facial plastic surgery at a slightly younger age as well? Because I do feel like there's this sudden movement towards, exactly as you said, doing everything in a holistic, sort of harmonious, beautiful way, but also not wanting to leave it too late, so that actually these changes that you're creating are suddenly incredibly noticeable to everyone.
Yes, so I am seeing patients at a younger age, and it's balancing the level of intervention, because any facelift is significant. It's not a lunchtime treatment, no matter what you hear about mini facelifts. So it's balancing when you intervene. When you're younger, your tissue's more elastic, and your skin will hold a lift better. But then you have to balance it against, do you actually need it done? And is the level of intervention justifiable? Yeah. And it is for some. And I have had some very young patients, younger than you might think, but there have been reasons like weight loss, or some have had a fat loss from previous procedures, or they have connective tissue disorders which affect skin elasticity and skin stretches more. So I have had patients have facelifts far younger than you would think for a facelift. But there is a reason, and they they have had something that benefited from a facelift. It's tailoring it.
And often with that younger patient, I see it sort of more and more. Actually, sometimes it's genetic, and particularly when you're looking at the neck. I think we often think about facelifts, neck lifts being done in isolation, but I'm sure you're looking at everything is done sort of together, isn't it? And when you are predisposed, maybe genetically, to a slightly heavier neck or a double chin, actually, this isn't even about aging. It's the way your anatomy was built.
Yeah, there are patients who have genetically very full chins. They're not overweight. It's not weight gain. It's not aging. They genetically have small jaws and chins and have very full tissue here, and they are one of the few groups that can benefit from sometimes the cool sculpting or liposuction, but they're also one of the groups that can benefit from an isolated neck lift, where you actually address all the layers. Again, it doesn't mean everyone has to have everything, but you can do things like chin implants to bring out the chin, which then brings the skin out more and gets a better line. You can tighten the muscle here, you can reduce fat if there is extra fat. There actually isn't always extra fat, even though it looks like a double chin. And you can reduce the salivary glands that sit here, because if the jawbone is small, they don't fit inside, so they come down and it becomes more obvious. That's a sign of aging as well, but it's not always aging. Sometimes it's literally the framework around it is smaller than average, so they come down. And
everything is dropping, everything is going south, wonderful.
And that's that can be a young person's operation.
Yeah.
But with aging, it gets worse quicker than in someone who doesn't have it.
And what about all of the little add-ons, the adjunctive procedures that actually really bring a face and neck lift to life? What are those sort of interventions that you might also be incorporating?
So the most common one is upper blepharoplasty, upper eyelid lifts, or lower blepharoplasty, lower eyelid lifts, then probably eyebrows, and then lips and noses. And sometimes chin implants.
So eyes are transformative. I once met a breast surgeon who said to me, if you only get one thing done, get your eyes done, which I thought coming from a breast surgeon was actually quite cool.
Yeah, they can be really transformative, and something like upper eyelid blepharoplasty can be done under local anaesthetic, and it is one of the smaller operations we do, but with a big impact.
Yeah, 100%. And what about techniques for the future? What are the things that you're sort of looking towards and thinking, this long term is really going to start future-proofing our faces?
Okay, so it's, in a very boring way, it's starting early with things like no smoking, sunscreen, but quite seriously, it is what
the day-to-day things. I mean, those tiny incremental things that you do every day do add up to the bigger picture.
They do add up. So it's things like that, is looking after your skin. It's looking after your health generally, because that is reflected in your body eventually. If you and there are reasons why people don't look after themselves. It can be looking after someone else, it can be life events, there are lots of reasons, but looking after yourself helps as well. Specifically, otherwise, you can consider smaller interventions early as well. So, as I mentioned skincare earlier, but things like wrinkle reduction, things like the non-surgical interventions can come in earlier. I would just caveat that check what long-term consequence there can be from non-surgical treatments if you would ever consider surgery, because some do affect how surgery, they don't stop surgery, but they do affect how surgery is done, or your risks from surgery if they create deeper scar tissue.
They make your job more difficult.
They make my job more difficult, which then makes your recovery more difficult.
Yeah, exactly.
So it's not a no. I'm not against them. It's just, if you would ever consider surgery, think about how things you would do before surgery would impact on the surgery, or ask that question. It's not a no to them, it doesn't stop surgery, but it's something we're becoming more aware of.
And looking towards the future, things like fat transfer, things like exosomes, like where do you stand on that?
They are really, really coming into their own.
Yeah.
We've been doing fat transfer for several years, but there's more and more recognition of the regenerative value in fat, not specific. So fat was initially used just to replace volume, because we lose volume, or to put volume in the right places, because you lose it here and it sags down here. So it's about balancing the face. But fat cells actually have many regenerative qualities that can affect the quality of skin, collagen production, reduction of ageing changes, and that's really coming into its own. And exosomes are an extension of that. They're not necessarily fat cells, but they're going along the same regenerative line. So I honestly, that is going to be a big part of our future.
I always think it's such an elegant solution as well, taking fat from somewhere on the body where you don't want it and actually seeing a benefit somewhere where you do. And then final question, moving on to the body work that you do, because I also think a lot of the body procedures that you do, and you touched on this at the beginning in your introduction, you know, the breast surgeries, the abdominoplasties, the labiaplasties, they strike me as even more so than the face surgery, very restorative in that you're, and again, you said this, you know, you're really reinstating somebody's physiology, but also their confidence.
Yeah, they make a huge difference physically and psychologically, and some of what falls under the big umbrella of cosmetic surgery is not actually that cosmetic at all. For example, I see a lot of women after pregnancy where their abdominal wall is stretched and they have a bulge they're not overweight, they exercise, they eat healthily, the bulge just won't go away, they have an overhang of skin. It can affect their back and posture, it can affect the ability to exercise, you know, it affects the clothing they wear, it really affects confidence. And exercise will help, and core exercises help, but they only go so far. It's a bit like we were talking about skin stretching earlier. The analogy I would say is, if you think of a pair of leggings, you take them out of the packet, you put them on, they stretch, you take them off, they shrink, but they don't go back to how they were in the packet. It's the same with our skin and our muscles. They will go back so far, and then it takes that extra bit to do the final bit, and it really does restore.
Particularly something like a pregnancy, which sounds awful to say, but it is essentially a trauma to the skin.
It's a natural event, but it leaves a trace. You know, it stretches far beyond what would normally happen in day-to-day life, and it's over a 9-month period or thereabouts, so it's not over years. It happens relatively quickly, and that's when, you know, it's the last sort of 2 months of pregnancy that the stretch marks start to appear, and that's a sign that the skin has reached its capacity. But remember, it's happening in the layers underneath as well, it's happening in the muscle wall as well, and it will go down, but it doesn't always go back to how it was before, and particularly a twin pregnancy or something, I thought.
Oh my goodness, can you imagine? I mean, it's so interesting, because I feel like everything that you're saying, I'm sure Mark will agree, and then Garry will agree when he comes to speak as well. It's very much about form and function, and
Absolutely.
I think that's
and that's the core
package.
of plastic surgery.
Agreed. Thank you so much, Nora. That was really, really interesting. And any questions that you have for Nora, please sort of save them up until the end, and we'll come to those when we're all done with the main discussion.
Thank you.
Thank you, Nora. So our next speaker is Professor Mark Whiteley. He's already introduced himself to you, but for me, Mark has always been my go-to guy when it comes to veins, or in fact anything to do with veins. I think there's not a single thing in the world of venous vascular know-how that this man doesn't know. But I think it's also fair of me to say you're quite disruptive in your industry, and that you're always challenging things and you're innovating, all with patient safety at the end of the day, which I think is highly important, and I personally love. But Mark, my question for you to start off with is very much about the sort of nature of veins, because I think when we do start to notice veins, it's often for very cosmetic reasons, isn't it? It's the spidery veins we notice, it's the varicose veins, it's even the ones sort of creeping around our temples. But actually, veins have a huge sort of impact on our underlying health, and I'd love to know sort of what we can do to change that narrative.
Yeah, I mean, the first thing that needs to happen is, if the NHS had consultant vein surgeons, then the medical schools would teach veins, and you'd have veins being taught all the way through at some time in your medical career. I have research fellows who come and join me before they go to medical school in the first year, and I promise them a paper if they work hard all summer, and they usually get one. And what we find is, when they write back to me at the end of their 5 years of training, they've had 1 hour on veins. And it's
this is crazy. You know, I also hear very similar things, sorry to interrupt you, when people are talking about the importance of hormones and menopause, and there's zero training on the menopause and the NHS. These very important facets of our health are just not really addressed.
And one of the big problems we have is we have a monopoly of health training in the UK. And so I'm not anti-NHS at all, but the difficulty with it is, and I'm sure facelifts and things like that, there are things that are in every speciality that patients want, and we have to provide for patients, but if they're not recognised to be done on the NHS, there is no training for it. And the plastic surgeons have been ahead of the game by actually having training in the private sector and been pushing for that. And we set up the College for Pathology about 11 years ago now, and it's now gaining traction worldwide, but still we don't get any English doctors coming on it. Because the whole thing, going back to your question, the difficulty with veins is, if you see veins, you've got them. So, thread veins, varicose veins, lumpy veins, bulging veins, all those. But if you don't have veins, you might also have the problem. So, for instance, 50% of people with leg ulcers have got them because of varicose veins and they've never seen a varicose vein in their life.
Well, so much lies beneath the surface, doesn't it? And I find that quite scary with veins.
So the trouble is with veins on the surface, they're the escape route. So basically, it is the analogy, which is very horrible, but basically if you jump off a building and you hit the ground, you sort of are obviously traumatised, and that's the hidden varicose veins. That's the people who have the dead straight veins with no valves in them, and they're the ones who turn up to the GP and say, I'm getting a bit of swelling and aching in my legs, and the GP says, wear stockings. You haven't got varicose veins, which is a lie, you have. And then you go on and you sort of end up with eczema if it's not treated, and you get some red stains and itching, and then you get the brown stains, then you get the leg ulcer, and then you get in the hands of the district nurses. And the rest of your life you're having bandages and compression. And the Everard study in Eschgar, both randomised controlled studies paid for by the British taxpayer through the NHS, have shown that if those patients, instead of going to the district nurses, if they went to a venous surgeon, had a duplex ultrasound, and the venous reflux was found and treated, they would heal. They also would heal faster, shown by the Everard study, and wouldn't come back again anywhere near as quick. In fact, you rarely get a recurrence.
Well, it seems like complete common sense that you would actually do the deeper dive, the proper investigations to really understand the root cause of the problem.
And only 50% of people with venous disease actually then develop this escape route, which is the same man jumping off the cliff but hitting all the awnings on the way down.
Oh, God, nice.
So he doesn't get the inflammation. And so the varicose veins are actually shock absorbers. So the trouble is, in one of my books, The Understanding Venous Reflux, my favourite book chapter I've ever written is Varicose Veins, the Good Guys, because actually the varicose veins you see on the surface are the things that take away the impact of the inflammation that causes the damage of the skin. So anyone who wants to take away the varicose vein is actually doing harm to the patient. What you should be saying is the varicose vein or the thread veins you can see is telling you have a problem. And then the doctor should be saying the problem's coming from your pelvic veins or your leg veins or your perforators. Treating that first, stopping the impact that's caused that vein to dilate, and then the varicose vein itself is then secondary to that. And that's only true though for veins under the heart. So not the facial veins.
No, fair enough, and that's a completely different conversation. So basically veins, when they're visible on the surface, are like the little red flags, and that's the sign that there is a much deeper rooted issue.
Much more importantly, then you should be lucky if you've got veins that you can see on the surface, because you're being told what's wrong with you.
Because often they are hidden and you wouldn't necessarily know that something was amiss. What is it that predisposes us to faulty veins? Is this lifestyle? Is this genetics? How can we sort of figure out what's causing them and know if we're going to get them?
And unfortunately, it's your parents, so you can't really change that, because the majority of it comes down to your genetic makeup. There are lots of things that are written that are incorrect, things such as crossing legs, diet.
I'm glad you say that, considering all of us.
All of it's been disproven, and pregnancy as well doesn't cause varicose veins. Otherwise you wouldn't get as many men as women having it. And there's a lot of mythology about veins because people don't understand them. And the difficulty is there's a difference between causative factors and associative factors. So for instance, you'll have to hear people say, and even the NICE guidelines say about obesity and varicose veins, where they're getting confused, and they were actually written by a vascular surgeon, not a venous surgeon. And the confusion that they've come across is the fact that the more you exercise, the more you keep the venous circulation pumping, so you don't get the stasis, you don't get the inflammation in the veins that causes the eczema and the skin damage and the clots and all the other complications. So you still got the varicose veins, but they don't cause so many complications. Now, if you don't exercise so much, you get more stasis, you get more inflammation, you get more damage, and you tend to be heavier. So it's an association. People who are heavier tend to have more severe disease.
Versus actually being the cause of why you would have them. And what are the symptoms that we should be aware of when it comes to veins? I mean, obviously the ones that are visible on the surface, we know that we need to go and have the duplex ultrasound and actually understand what's going on at a sort of deeper level. But what else can we be attuned to? What else might we be experiencing in our bodies?
So although it's a systemic problem, the good thing is veins above your heart, which includes your arms because they're above the heart, they don't cause damage, they're more cosmetic. So we can talk about aesthetic phlebology above the heart. Below the heart, we have to divide it really into two sections. So you've got leg veins, which everybody thinks is varicose veins, and pelvic veins, because that's what's been the big buzz in venous surgery for the last 20 years. So if we look at, it's really well established now in leg veins, and it's in the NICE guidelines, it's in a reactive study. We know that if you get tired legs by the end of the day, if aching legs, or there's symptoms, so it's rarely pain. You only get pain if you've got a thrombus.
Mm-hmm.
So these are just tired, aching legs that feel better when you put your legs up. You've probably got venous reflux. If you don't get it fixed by then, you go on to edema of your legs, a bit of swelling, you see the imprint of your socks. You then go on to skin damage, which is eczema, first of all, itching, then redness, then brown stains, then hardness called lipodermatosclerosis. Then you get venous leg ulcers, which are open sores. And that's the progression. Not everybody goes through every stage, but that's the progression. You also have on top of that superficial clots, superficial thrombophlebitis, as it's called, which is actually thrombosis, and you also get bleeding. Now, above the inguinal ligament, in other words, in pelvic congestion, we know that 25 to 40% of women of childbearing age have got venous reflux in the pelvis.
Wow.
And we know that if you go to gynecological outpatients, 1 in 3 women in there have got pelvic congestion causing their pain, and the gynecologist will not engage, and they get diagnosed as endometriosis or there's nothing wrong with them. And all these pressure groups saying about it, and it's actually pelvic reflux. And if you talk to gynecologists and say, what do you find? They all say, well, you go inside and they've all got these great big veins, but we didn't find anything wrong, she's probably nuts. And they're seeing pelvic congestion and they're not recognising it. And the
That sounds so dangerous.
Well, the good thing is it's not dangerous. All it does is destroys your quality of life.
Yeah.
And so it doesn't kill you, and that's the problem, because if it doesn't kill you, not many people are interested.
So what are the symptoms you need to be mindful of for the pelvic vein congestion?
So I wrote a book on it, and the way I've decided, because at the moment, because it's fairly new, there are lots of different people with lots of different ideas, but the way I look at it is you've got signs and symptoms, which is the signs of things you see, symptoms of things you feel, and you've got inside the pelvis and outside the pelvis. So inside the pelvis and the symptoms, which is the biggest, so basically everything that gets inflamed in your pelvis. So the irritable bowel, irritable bladder, an aching, dragging heaviness on your pelvis when you're sitting or standing that gets better when you lie down. It goes on for more than 6 months. Then you get pain on sexual intercourse either during or after, but it's deep pain. It's not superficial, it's Bartholin's glands. A lot of ladies who have got irritable bladder think it's because they've had children. It's actually because they've got veins all around the pelvis that's irritating the bladder. So irritable bowel, irritable bladder, heavy, dragging, aching.
This is fascinating because, I mean, sorry to interrupt your flow, but these are all common symptoms that I imagine women are going to see their gynecologist about. Exactly as you say, you wouldn't necessarily associate this with, I need to go and see a venous or a vascular sort of consultant.
Just put a paper up on the College of Pathology preprint server, and it's just about to be accepted for the Journal of Vascular and Endovascular Surgery, and it got turned down by every single gynecology and obstetric journal put it into, showing the benefit that women get if they think they've got this long-term aching pelvis, and you then cure it. The people who are most satisfied are people who haven't been diagnosed for over 9 years.
Wow.
And in the Western world, to have that, I actually had an Irish patient I did a Zoom consultation with this afternoon, and I was talking to her about something else because we've cured her pelvic congestion, and she has now got a rotator cuff problem because she's walking with a crutch because her pelvic pain was so bad. And she kept on being told it's endometriosis, but they couldn't actually find any intramural tissue. Then she was told all these other things. Then eventually it was so bad, she came to us and said, don't know, just see if it is. She had crashing pelvic congestion, she had coil embolization, and she's now back to normal. She's gone back to normal life. But the difficulty is, because of the crutch, she's now got rotator cuff problem, and so we're referring to orthopaedic.
One thing sort of has an impact on another, doesn't it? It's like a domino effect. One thing falls out of line, and Gary's nodding. He's like, yeah, this is what happens all throughout the whole body.
Yeah.
What are the sort of gold standard treatments if we do have varicose veins? Because I feel like this is something that gets asked time and time again. What do we actually do? Because there's a lot of controversy around the best treatment.
Yes, so the answer to that is it's the wrong question, which is, I don't want to be rude, but
no. We asked the correct question.
So the problem is there's been a plethora of different vein clinics setting up all around the country offering cheap treatments. And it's not whether their treatments work or not. The big problem they've all got is they aren't treating the right veins. So if you don't have the roadmap, you're not going to get the right treatment. So in the NHS and our medical schools, we're still taught there are 2 veins that cause varicose veins, and that's why it's easy. The great venous and small venous, although most doctors still call them long and short, even though that went out in 2001. However, research shows you've got 160 different veins that any combination could cause varicose veins, including pelvic veins going into the legs, incompetent perforating veins, or the 4 or 5 different sorts of veins, Giacomini vein. And the difficulty is if a doctor does their own quick scan and they're not trained as a vascular technologist and it takes like 2 minutes, 3 minutes, which is normal, they're only checking those two veins. Now you can have the best laser, radio frequency, micro, you can have the best treatment in the world, but if you're not putting it in the right vein, you don't get good treatment.
100%.
So
it's treatment plus the hands that are administering it at the end of the day.
You've got to have the roadmap. So that's why our clinic will, regarded as expensive or not, what we do is we actually do a proper scan. So a scan takes 20 minutes a leg and it's done by people who do nothing but venous scans all day, every day, vascular technologists. And you have to use the 4-eye principle where the doctor is never allowed to do their own scan because they're just not trained to do it. And then once you have the diagnosis, then you can actually treat them. Now when you use the treatment, the principle is very simple. For venous ablation, you have to kill all the cells in the vein wall, all the way out to the adventitia. And you can use laser. Radio frequency is not quite as good. You can use microwave nowadays. The latest thing that is the big buzz is this thing called Sonovein, high intensity focused ultrasound. I know you use it for the skin, but this is focused. So you put the ultrasound on the skin, you see the vein. Obviously you can't close it because it's full of blood, so what they've invented is a balloon that pushes it, it closes the vein completely shut, and then you beam the ultrasound and it fries the vein, and it actually basically gives you that heat that causes apoptosis and the vein dies, and then you work your way down the leg. At the moment it's still very new, there's only one machine in the country, which of course is in our clinic, because they brought it to us to try out, and we've been doing lots of research, going around the world and presenting our research on it. I wouldn't say at the moment it is a very, very exciting way of doing it, but it's for people who have a lot of patients and don't want needles. It's not at the moment a commercial venture, it's still the thing
it's coming in the future, exactly, it's one to watch. And what about sort of looking to the future? I mean, whether or not we've had treatment, whether or not we've had varicose veins, what are the things that we can really be doing to future-proof our venous network, our sort of veins and our vascular health?
So I'm just about to fly off to Georgia to give a debate on post-thrombotic syndrome, which is one of the problems you get. And even if you've got very, very simple varicose veins, and then you get a thrombosis, if you've had simple varicose veins before and you get a deep vein thrombosis, you're more likely to get permanent scarring in the deep veins.
So it's about sort of avoiding even trying to get...
And everything points towards that rather than the old people, the old idea that you leave veins until they cause a problem. Now, as soon as you get those indications of tired legs, or start to get swelling, anything early, now even the NICE guidelines say that is the time you get them treated. Because if you do so, your quality of life is better within 2 years, even compared to the worst surgery. And if you have the good surgery, like it's within a few months, you get that crossover. So this hormonal medical probe is not opinion anymore. It is actually now part of the literature with randomized controlled studies showing it.
And what about the things we can do from home? I mean, are there any benefits to exercise? I guess sort of looking after the lymphatic system, are there links to that, to reducing inflammation?
Yeah, I mean, so the most important thing I think that's come up in the aesthetic world and in all worlds is almost everything that damages you is linked to chronic inflammation, as you said. And chronic inflammation is the killer. Acute inflammation is healing, that's good. Chronic inflammation is bad. And we see that, so everything we aim in venous surgery is to try and stop the chronic inflammation. So exercise uniformly is good, especially if you use the ankle joint. So walking, running. Cycling's not quite so good. You don't use the ankle joint, although everybody outside is obviously cycling like mad. Swimming is okay because it's like wearing compression stocking, but walking and running is still the best thing to get the veins pumping. The blood doesn't sit there, it pumps up, you don't get stasis, you don't get the inflammation, you don't get the reflux. What kills your veins is sitting still, doing nothing without wiggling your legs or standing long periods. The lymphatic system is completely different. The lymphatic system actually has peristalsis like your gut. In fact, the lymphatic system, if you just watch it, will keep on constricting by itself. And there's been some amazing work that's been done with the new, I can't remember, I'm sure you know, that we used to put the x-rays, put contrast in the x-rays, lymphocintigraphy, and the lymphangiograms, and now there's a thing that came out of America about 15 years ago where you can actually put a fluorescent dye into the lymphatics at the toe. You can put a heads-up display, you can shine a laser, and it reflects back fluorescence, so you can see the lymphatics actually working.
That's so cool.
And so now, if you've got lymphatic blockage, the very clever plastic surgeon, I don't get into this, but the very clever plastic surgeon can actually say whether you're just they're a bit overstretched and therefore manual lymphatic drainage will help clear them, or whether they actually have a blockage because of damage, in which case a little lymphatic bypass will work. So I don't get into that, but the majority of people who have got dilated lymphatics, and you can usually tell that because the swelling goes all the way to your toes. If your toes are involved, it's lymphatic. If it stops at your ankles and upper foot, it's veins. I'm a great believer that you should also have lymphatic drainage. The thing with lymphatics is you can't just go for a walk because your muscles have to push against something. So if you want to do it at home, you wear a tight stocking or a toe bandage and then go for a walk, because you've got the two things. You've got a wall and the muscle pushing towards it, and you help that. I think brushing,
like the dry body brushing.
Yeah. The manufactured drainage, to always do it upwards with the lymphatics and get an idea where they are. All of these things, and I've just done a research study with a company which I didn't think would work, and it does, about new anti-cellulite pants, and they actually work with compression things, and the whole idea.
I remember being sent some of those years ago, like special leggings that were like anti-cellulite, and sort of, I don't know if they made a difference. Maybe your stuff.
It's not mine. It's not mine. I wish, but this fellow called Steve Barker's invented this an imprint on the side. We've just done a study where we've got compression pants which we know improve cellulite, and we've just got one side has got this impregnated stuff and things on the inside, and the other side hasn't. You can see a difference in 70% of people within 3 months. So, and this is...
And where can we buy these?
I'll show you making those chairs.
The next good imagine.
They're coming out this summer. We're just about to publish the paper on it, and so it's phenomenally interesting. But I don't do that as a sales pitch. I do it purely and simply to show that it is the micro massage. That is the whole thing about it is. If you either sit there and let someone massage you, or you do it yourself, or you move. But if you move, you have to, unlike veins which you can contract by movement, with lymphatics you have to have something solid to contract it against.
Which is why you're saying why the stockings when you do it. Wow, gosh, I mean, it's so connected, the vascular sort of network, we're talking about sort of gynecological issues that we might be having, we're talking about the lymphatics, about cellulite, and it's very far-reaching, the work that you do. Thank you, Mark, that was super interesting. And any questions for Mark, we'll have time at the end. So our third and final speaker is Garry Trainer. You all now know who he is, and also his story, which I didn't know, and I think that's fascinating, sort of your background to sort of becoming an osteopath. I actually met Garry, 12 years ago, I think. I came to a clinic in Primrose Hill. You were the first person to ever crack my neck, and it really took me by surprise. But I felt amazing afterwards. I mean, you sort of already spoke a little bit about sort of your journey to becoming an osteopath, but tell us a little bit more about how it is that your treatments actually work. You said it's a combination approach, but how do you sort of figure out the best approach for the individual?
The most important thing in treatment is to get a positive diagnosis. Especially with back pain, because there's so many causes. So we use, I would get everyone scanned if I could, but unfortunately we can't do that. So when you put a person through an examination, you're looking at their ranges of movement, and everything they can do is of no interest to me at all. It's the things they can't do that become of interest. And then from that you can work out what they need.
And does everybody have, you sort of mentioned the massage, you mentioned the acupuncture, and then you mentioned the osteopathy. They all have very different sort of reasonings behind them, but does everybody sort of tend to follow that format? Does that
If I can have my way, that's what I would do. But there are people who are needle phobic and they don't want you to put needles, or they don't want to be cracked, so you don't do that. So you have to adapt to the patient that you have.
Yeah.
So you've got to be careful that you don't scare them too much.
Yeah, exactly. Could have gone one way or the other when I had my neck cracked by you. Luckily, it was a good experience. But what are the main reasons that people are coming to your door? I mean, you mentioned back pain and your personal experience with that. Is that one of the key drivers? Because you also see, leading people from the worlds of performing arts and sports and all sorts of amazing backgrounds.
Just there's one thing about the word disruptive. I've got something in my bag here that will just throw everybody.
I love it when people bring a prop.
Yeah.
That's why you wouldn't let me move your bag.
We can come back to it at the end. But
oh, wow.
I wonder what they've got to do with back pain, but at the end of it we can tell you what they are.
Are they cowboy boots? Are they cowboy boots? Are they yours?
Not mine, no.
Oh, okay.
They were given to me.
Oh, okay.
So what was the question you asked?
I was asking why most people find their way to your door, whether it was back pain, whether it was sort of maintenance, performance, given the people that you treat.
80% of back pain is what we call mechanical. It comes down to just making the wrong move at the wrong moment. Those sort of back pains often get better by themselves. There's a sort of a pattern of mechanical back pain is that the onset can be really abrupt. It can take your breath away. It can scare you. It can come on really fast. Then the following day after that, it goes to more of a bruised feeling. And then the day after that, it starts to subside a wee bit. So when people phone me saying, I've just done my back, I suggest that they take a couple of days to let time run its course, because time is the greatest healer, and if you give time, most things do get better. But with mechanical back pain, they get better, and the pattern is, say, 24 hours unpredictable, 24 hours you feel a bit bruised, next 24 hours the symptoms subside. And if you get that pattern after 3 days, you could leave it alone, it'll get better by itself. And 80% of back pain falls into those categories. There's another category of back pain where you've got, tumours, infections, slit discs. These require a little bit more care. And to be sort of pain-free and have efficient movement, the musculoskeletal and nervous systems must be working in harmony. So you have a nerve impulse that gets fired down the nerve into the muscle. The muscle then contracts. It then pulls one end of the muscle towards the other end of the muscle, and that creates movement. If one of those systems isn't working, you're going to have pain, or you're going to have dysfunction. So
it's amazing, sort of looking at how you've just described the body. The way you picture it is just like an incredible machine, and everything has a knock-on effect. Every system,
yes, and hearing the sort of side effects and the rotator cuff. Whenever I treat anyone with a neck problem, one of the first places I check is the lower back, because if the lower back or the pelvis is twisted and you get a short leg, then you lean that way a little bit more. Once you lean one way, then further up the spine it compensates, and then it compensates, and then it gets to the neck and it can't go any further. So people often get neck pain because they've got a twist through the pelvis.
And they're always really surprised when they say, it's in my neck, and you start sort of manipulating their pelvis, and they're like, no, it's my neck, not down there.
Yeah, and I've got to say, that's one of the beauties of working with age-old treatments, even though I'm very much into the advance of technology. For things like acupuncture to last 5,000 years, you've got to think there's something going on in there. And it's not until, I work with the football team, and I've been trying to get acupuncture and osteopathy into the sports medicine department forever, and it's only really in the last 15, 20 years since some neurologists did some research into acupuncture. They were researching a thing called TENS, which is transcutaneous electrical nerve stimulation. And what they do is they take a sample of spinal fluid, then they sort of bombard a nerve with electrical current, and then they take samples of spinal fluid again at the end. And they were able to measure the increase of production of what they call endorphins. Now, endorphins are a neurochemical. They have a similar chemical structure to morphine, and they have a very strong pain relieving effect and calming effect. So acupuncture was the first one I trained in, and I thought it was amazing. I did that for a couple of years, but I didn't find it asked enough questions. I wanted to know what caused the pain. It was great to have a technique that took the pain away, but why? So there, osteopathy was a really good subject to learn, because it tries to establish, is it a muscle, a nerve, a ligament, a disc, a bone, a tumour? So to know what you're treating is the most important thing. And unfortunately, with back pain, most people, if you present to them, will say, oh yes, I'll take you on as a patient. You're going to see a neurologist, or you're going to see a psychotherapist. I'll be asking about your relationship with your mother.
It can sort of be relevant to sort of so many different practices.
And it could be your diet, and it could be your posture, and it could be all sorts of possibilities.
So true.
But there's going to be something that's specifically right for you. And I think to get to that sort of practice is the most important thing, and not to waste people's time and their money.
100%, and I think everyone will always appreciate that, especially if they're just trying to deal with the back pain. What about pain in sort of particular? Is it normal? Like, is it normal to be in pain at some point? Is it part of
pain
sort
is a
of
normal thing. I think people who believe that we shouldn't be in pain are sort of a little bit deluded. Pain is normal. It's a warning sign. It tells us to take attention, pay attention to certain things.
I suppose the difference is sort of when it's just that sort of wear and tear of that sort of accompanies age versus the acute pain that you discussed right at the beginning.
Yes, that's right. Sorry, what was your question?
No, sorry, I think I interrupted you and now I've lost my question. But on the note of pain as well, is it also a result of the sort of evolution of human beings as well? You know, the way that we live our lives now is very different to how human beings were designed to move and act and function.
Yeah. Ideally, if you look at an animal and you see the spine is perfectly suspended between the four limbs, there's no real compressive forces going on. As soon as you put it upright, You have all the downward pressure of gravity. The fifth lumbar disc, which is the last one in the spine, takes all the load. So there's certain ways you can take, that's where you sort of get into exercises and getting, having good core stability. My favourite piece of equipment that people could have in their home is a thing called a wobble board. And
is that what looks like half of a Swiss ball?
Yeah, it's half a circle and it's half a ball underneath it, and you stand on it and you wobble all over the place, and you've got to stabilise, and that pulls into play all of your core muscles, and it also mobilises the ankle, the knee, the hip, and the lower back all at the same time. If you just roll around the circumference of the board. So that's a really good piece of kit that people could have at home. And
actually it takes up no space at all, and it takes no time to do. That sounds absolutely genius. I need to get one immediately.
Yeah, I think one thing that's really important is to understand that the spine only moves in 6 directions. It flexes forward, it extends backwards, it side bends from side to side, and it rotates from side to side. If you want to stretch your back thoroughly, you should be doing it in 6 directions. The 6 stretches, you can perform them while you're sitting, lying or standing. And a stretch is when you go to the end of range of movement and then you go that little bit further. That's where a stretch takes place. So when you do a movement, you get to the end of range, you go a little bit further. That's where you get the benefit of the stretch. And you should just, when you're doing those stretches, just focus your mind on the area that you're stretching, and then you keep doing it. So you've got to feel it. So they say a stretch is assisting the body in its movement, and if you want to strengthen a muscle, you resist the movement. So that's where you start getting into sort of different exercises and using exercise bands and rubber bands to resist the movement.
So healthy human movement is only really going in 6 directions, but what are the sort of movements, I suppose, that we should be avoiding? What are the things that are actually causing more damage to us?
I think the worst movement is when we extend backwards. That compresses all the structures of the spine. And
sort of like a yoga back bend.
Yeah, so I always say that when it comes to stretching, you should do the 5 other stretches first. So I always start with a flexion stretch, bending forward, because that opens up all the structures of your lower back. Then you can do your side bending, your rotations, then do extension last.
And what's, if you could give us one stretch to do that would benefit everyone here, what would that be? I love the fact, by the way, you said that you can do them sitting, which, because I think, we can live such sedentary lifestyles now, it's probably the only time we'll do it.
Sitting is one of the best positions to get a flexion stretch, because if you're upright, your hamstrings are part of the movement. And if you've got tight hamstrings, often you can't bend forward and even touch your toes. Whereas if you bend your knees, that takes the hamstrings out of the equation, and you can actually get a much, much, much better range of movements. So sitting, there's no hamstring involvement.
It's almost like you've bypassed the hamstring, which is often the thing that catches people and prevents them from doing it properly.
But a lot of people have tight hamstrings.
Yeah. And then you see them in the gym sort of straining to touch their toes or sort of sitting down and you're just never going to get anywhere.
In fact, what happens is you create back problems.
Yeah, and then we're back to seeing you again, literally.
We encourage people to do exercise.
What would be your final sort of top tip for future-proofing our bodies? I mean, we've spoken about stretching. Is there anything we can do for posture, to really... I mean, you only have to sort of take the bus or the tube and just to see everyone with their neck sort of craned forward and sort of looking at their phone. And I just think long-term is doing horrific things for all of us.
There is a thing called tech neck, which is basically we do our head forward like that a lot. I think the key is just keep moving. It doesn't almost matter what you do. Whatever you enjoy doing the most, do that. But you don't do it with intensity or load. So with the football team, the way we prepare them before they play, is we get them to kick a football. But we don't do it with intensity. And once they've kicked the football a few times, they can start kicking it a bit harder and harder. So the best way is to do what you enjoy doing without intensity or load, and then gradually build it up. So if someone's had an injury, we'll get them running in a straight line first, and once they can do straight line running, then we'll start introducing some movements from side to side. So it's how you build it up is the most important.
It's such a commonsensical approach, and it's, I think going back to all the things that we've discussed today, actually none of these things are rocket science, but actually sometimes it's the boring, slightly unsexy, everyday things that really do make the biggest difference.
Yeah, that's true. to. It's simple at the end of the day.
I love that. Thank you, Gary. That was equally fascinating. And any questions for Gary? In fact, well, that very much brings us to the end of the conversation for tonight anyway. So we will have time for questions. But I'd just love to say, how fascinating I found it all listening to you. I mean, I know all of you individually. I've been to your clinics. I've had treatments with many of you. Everyone apart from Nora, actually, but that will come in a few years when I've had another baby. But actually, it's so fascinating because we've gone from talking about tissues and fat to veins to lymphatics to bones to muscles to nerves, and actually just listening to all of you, and I'm sure you'll all agree in the audience, everything is so interconnected, and the human body is such an insanely sophisticated, intelligent machine, and I just think all of you explain the importance of really looking after it and treating it holistically so beautifully, and whilst also underlining the importance of just good common sense and simple solutions, which is always helpful. We do have time for some questions now. I saw one or two hands go up throughout, so I'll come straight to you. If you do need to rush off, then don't forget your goodie bag, please. We'll sort of have them ready to give to you, and also don't forget to hand in your referral cards if you'd like us to connect you with anybody. I think there was a lady here in the green who had a question right at the start. Over to you.
Me? Yes.
Yes, you.
I have a question for plastic surgeon. First of all, I would like to thank everybody. It was an amazing lecture. I have a question about doing facelift. What would be the right age if there is a great skin care and it's like no smoking? What would be the right age?
There isn't an age. It's not the number of years. It's your face. First of all, is it bothering you? And secondly, is there enough aging for me to change with a facelift that justifies what's involved? So I guess I start generally seeing people in the most common age is probably 50 upwards, but I do see patients in their 40s. I have had a few in their 30s, which sounds extraordinarily young for a facelift, but there have been other reasons. But it's not the age, it's not their date of birth, it's how much aging there is in their face. Some people age more rapidly than others for various reasons. And is there enough aging to justify what I do? Because it's not, it's not an office treatment, it's an operation. So it's not the absolute age, is what I do justifiable and will it benefit them? So it's balancing that. I would say most commonly, the younger end of facelift patients are in their 40s to 50s, the average are in their 50s to 60s, and then you also see people in their 70s and 80s. And you can operate on older patients too, provided their health is good enough. It's not the age on the sheet of paper. It's what can I do, and are they fit to have it, and will it bring benefit?
Can I ask you just to go a little deeper into that? You once said to me, because obviously Nora is also a body surgeon, and we were once talking about how to know that you're suitable for a breast uplift. Mm-hmm. And you gave me this really fantastic example where you said, stand without a bra in front of the mirror, put your hands above your head, and dependent on where your nipple sat on your breast was relevant to whether or not you needed an uplift. Is there something applicable for a facelift? Is there something that will happen to the face or the neck and you'll go, now that has happened, you're a good candidate?
It's not. There's a much simpler way with the breast, as we described. With the face, it's if every time you catch sight of yourself in the mirror, it doesn't feel like you, or it feels tired than you feel, or people are always saying, are you tired or cross, and you're not. It's just, and I guess one thing is if you lie down, and you can't, it's hard to do this on yourself, but if you lie down and you took a photograph of yourself lying down, you've eliminated gravity. And if I examine facelift patients standing mostly, but I also get them to lie flat, and I look particularly at this area, and that eliminates gravity. And if that's what you would prefer to look like, then maybe it's time to see me. It's balancing, but it isn't. It's simpler for something like the breast or the tummy, but that if you lie flat and say you take a photograph of yourself lying flat, not too close, because selfie angles are actually, from a plastic surgery point of view, totally the wrong angle and camera to use to assess anything. So ideally you get someone else to do it, but if you're on your own, you take it from as far back as you can, and you take it from the front and the side. And if you look at your face and your neck and jawline, you've eliminated gravity, and has that made a significant difference? And if things have smoothed it out and this has gone flat and this is, you have a better angle, then maybe I can offer something. If there's really not much difference, then maybe it's too early. It's just things like that.
That's really interesting. Yeah, it's a completely 3D structure, so I suppose, if you can sort of take gravity away and see what it looks like without things dragging it down.
And also, one other thing you can do is, in some cases, I don't get patients to do this because it does involve them doing a bit of homework. But if you say, look at a photo of yourself from in your 20s, in your 30s, in your 40s, in your 50s, and just look at how your face has changed, look at the volume, look at the length of your lip, look at here, look at the changes, and if there's not much change, well, I don't need to see you. If you see that gradual progression, and it's got to a point where you're very far away from where you want to be, then that's another good time.
And you often, I suppose, like patients to bring in photographs as well,
it's
so
very
you
helpful.
can see that.
Because you can see what's aging and what's anatomy.
And I suppose also somewhat what you're trying to restore. You never want to take anyone too far away from where they started out.
You want to keep the individuality, and you don't want to turn someone into a different person by and large. You want to just restore. So it is helpful to see how someone looked 20 years earlier or 10 years earlier.
Yeah, absolutely.
It also lets you see the pace of aging, whether someone's aging normally or faster or slower than usual.
Exactly. This lady in the front here.
Yeah, just a follow-up question for Ms. Nugent. Is it easier to rectify the skin laxity of a patient who has undergone O-therapy and threading, or are they most of the patients?
So that does have an impact on facial surgery, because it creates scar tissue in the deeper layers, which are the layers. I'm not lifting the skin really. The skin is the second event. I'm lifting the support layer, which is deep to the skin, and threads are supposed to be in the layer between the support layer and the skin, but they leave scarring. Remember, anything that's stimulating, it's stimulating scar tissue. Collagen, it is collagen, but it's scar tissue.
Even when people say it's collagen type 1 and that's the one we want, you think there's still a bit of a grey area around
leaving polynucleotides and skincare out of it, but things like Ultherapy, Morpheus, threads, all of those create scar tissue, and that's how they're working. That collagen is scar collagen. Again, I'm not saying they're bad treatments. They are good non-surgical treatments, but they do leave an impact if you want facial surgery down the line. They don't outrule it, but they have created scar tissue. So it's a bit like if I do a facelift on someone and they come back 20 years later for a second facelift, the second one's more difficult because there's scar tissue from the first one. Well, it's the same. And it does vary. I have seen patients after, for example, Morpheus who've had, honestly, it was like nothing happened. There was no scar tissue. But I've had other patients where everything was really stuck and scarred. So for those treatments, always ask about the long-term consequence. If you would never consider surgery, it doesn't matter. Use them for the initial effect. But if you would ever consider surgery, and the same for lower eyelid treatments, ask and then think about the long-term effect. Ask what layer they're treating. And if they're treating the deeper layers, the chances are there will be some scar tissue that can affect surgery down the line. It doesn't stop it, but it does affect it.
And also there are sort of links, I don't want to point fingers at anything, but also to degrading the fat as well, which I think as life goes on, time goes you want to look after your fat.
For most people, you want the fat in your face and neck, because actually it's anti-aging in the long run. There are exceptions. It's not, and there is fat that goes out of place.
Well, then there's that
most people,
trend
you want to keep the fat in your face and neck. You don't want to melt it away too much. It's anti-aging.
And there was that whole trend in facelift surgery for the buccal fat removal, right? Like it was a big
thing. Got to be very
thing
careful about
in
that.
LA, but you wouldn't really touch that unless...
In a young patient who doesn't have an overly full face, I would be very, very cautious. They will not age well. It's fine in their 20s, it's not fine after that.
Yeah, exactly. I mean, that's the problem, isn't it? Sort of people are looking for the quick fix and they actually forget what that might look like.
It doesn't age well. It doesn't age well at all if it wasn't excessively large to start off with.
I think we've got to be so mindful of the quick fixes, haven't we? And all the work that Mark, it must be the same for you. Sort of the people looking for the quick fix, like quickly just blitz that spider vein that's bothering me on the side of the leg. But actually, you've got to almost go for the longer, more involved route, haven't you?
Yeah, I mean the trouble we have with the aesthetic clinics and beauty clinics and spider veins on the legs is because it's under the heart. It's in 90% of cases there's an underlying cause for the spider vein and thread vein. Now that usually means that you're just wasting your money. But if you're using one of the systems that shouldn't be used, like external laser, it's been shown that the amount of power that you need to get rid of a thread vein on the leg is enough to burn the skin. So you usually end up with skin burns or an ineffective treatment.
Mm.
It should always be sclerotherapy, but you should never do it if you've got underlying reflux. The best thing, you've just wasted your time and your money. Worst thing is you start getting scars. The very worst thing of all is a process called tenangiotic matting, where you end up with this great big strawberry-like birthmark, which is raised. And they used to say, if you look it up in the literature, they sort of said it's an allergy to sclerotherapy. It's actually been shown in every single case there's an underlying missed reflux. So in other words, a perforated vein reflux or anterior accessory, or the one of the veins that's been missed hasn't been treated first. So in our clinic, we are absolutely rigid when people come to us and say, can we just do the thread veins now, we'll come back and do the varix veins later. The answer is always no, because if you get the tenangiotic matting, you can't get rid of it. It's impossible to get rid of. So you have to do things in order. So you switch the reflux off first, you make the thing work, and then you do the cosmetic bit afterwards.
Very sensible. I would expect nothing less. Were there any other questions from the audience? This lady in the front.
Hello. That was a great, very informative. I've been lucky enough to see you many a times, Mr. Whiteley.
Die hard in the front row.
Die hard. You won't recognise me because you're so hard to get hold of. But
I recognise your legs
one
though.
of your consultants there, which Beijing. I've forgotten his name as I'm getting older. But anyway, my legs are really good, and you are brilliant, and I can actually, honestly, hand on heart, say that. I had a vein embolisation, pelvic embolisation from you, and obviously with all these aesthetic anti-aging processes that are heat-related, seems to be sort of slight challenge because lots of doctors are slightly nervous of it and I've got things. And you were just talking about this new treatment that you've got that heats up. Does that affect, because the coils that you have, as I understand from the vein embolisation, which are platinum, I believe.
That's why it's expensive.
It's about 18 years ago I had them done, and actually I've just had to stop kidney stones, so I saw the whole coil in the scans. But all these latest sort of treatments that slow us down, whether it's RF, whether it's any sort of treatments, and the one that you're talking about, does the vein embolisation affect those treatments? Because lots of doctors are quite nervous. Directly, I said I've got metal. And actually, sort of talking about anti-aging, I'm 58 years old, sort of, talking about the gynecological side of things, with going to my, gynecologist about that, and it's interesting, so I need to come and see you. And you talk about, your pelvic floor and tightening and all the machines. Are any of those, anyone's like, oh, no, God. But
It's that sort of,
does
one thing sort of, stop you from getting something else?
It's such a good question because so many people are terrified of having metal coils, and that's because they sort of they don't. I'm talking about doctors now. Doctors don't look at actually either the layer they're looking at, So basically, if it's deep inside you and it's actually in your veins that have now shriveled away, so there's just a protein cover. To have a skin treatment or something away, it's never going to have any effect at all. Right. In fact, the other thing is that they're non-ferrous, so they're not magnetic, so therefore they don't heat up with other things. They don't induce heat in them. You can go through an MRI in them. They've got only a trace of nickel, but they're virtually impossible to get an allergy from. So the reason we use them is they're gossamer thin. I mean, if you look at them, they basically, although we call them coils, they almost look like the pits of cotton with then fibres outside to irritate, and they're trained, so as you push them out, they actually whip round and they make the vein go to spasm and then kill it. The thing is, we can't use heat inside the body, because if you put a laser in there or something to kill the vein the same way that you do for the leg veins, you'd actually end up burning the bladder or something nasty. So we had to find a cold way of doing it. We actually have invented, and I've patented, a new way of doing it which doesn't leave metal inside the body. And we put out to try and sort of get backing for that, because obviously it takes a long time to get inventions out, and we've got all these inventions coming. So I started putting out a survey monkey saying how many women who have pelvic congestion would like a coil-free, no metal way of treating it, and 50% of people say they would actually put off having pelvic embolisation if they could have it without metal. So we know there's a huge market for it. The only trouble is to make a medical device for the medical market, even if you have all the money that you need, 3 to 4 years before it even sees the light of day. So the moment we're stuck with coils as the best option. There are worse things out there, but the coils is the best option.
Yeah, you're brilliant.
Oh, thank you very much.
My legs.
How much do I use?
It's like you replaced that.
You have to tell me, I'll have to sort you back. back to my list.
That's too funny. That's one way to fast your track to the top of his rating list.
No, you are, but but it's so interesting. I mean, you're all brilliant. I'm lucky enough to know Nora as well. I can see you.
Super fan. Were there any other questions? Lady in the pink.
I had a question for Garry. As an osteopath dealing with muscles, joints and ligaments, do you think there's a place for taking collagen rather than from a skin perspective, to take a collagen supplement to help?
Yes, yeah.
Yeah,
I think
okay.
all the sort of connective tissues, it's important for sure.
And bovine rather than marine or vegan? Do you think bovine is the...
But they have different beliefs about different sorts, so
Yeah.
whatever your individual belief is.
Thank you.
Just building on that as well, because I wanted to ask you about the effects of things like cryotherapy, because more and more people are looking towards practices like that, and they say it releases like growth factors, and it sort of dulls the sensation of pain. And you've obviously worked with sort of big sports teams, and they were always the front runners and things like cold therapy. Do you see that really having a difference with back pain?
Cryotherapy is getting very popular, but if you look through time, hot and cold treatments have been used since day dot. Both of them desensitise the nerve endings, both of them have a pain relieving effect. Heat's better for stimulation of circulation, whereas ice is better if there's inflammation. They say if in doubt, use ice is the better way of doing it.
And I have to ask you, what was the prop for in the end?
Oh yes, the shoes. Tell us about
You're going to put them on
the
at the end for
No,
us.
there's no link at all. No, in 1988. Does anyone recognise the boots? No. They were given to me by George Michael.
Oh, wow.
In 1988. He had a bad back, and I was retained, and I went on tour with them for 5 months around America and Canada and Learjet. And at the end of the tour, he gave me them. So, and George has been a great funder of the osteopathic profession over the years, and has helped get it established. So, I was very lucky, and I knew him for 30 years and got to sing live, probably more than anybody else. So, I was very lucky.
Oh my God, that's an amazing story. I love that. Oh, I'm always sad that I never got to see him live. Was there another question? The lady in the green cardigan.
Yes, I have a question about veins. From your perspective, if there are no issues with veins, as a preventative treatment, you would recommend to wear those compression stockings or leggings? How often we should wear them as a preventative treatment?
No, I don't think. I think if you're normally active and you're normally healthy and you don't have venous disease, I don't actually see the advantage of wearing compression stockings at all. And I know the Americans in particular, and the companies are so rich because they've persuaded everyone that if you stand up you must wear them.
Yes.
And I don't see any. My whole aim is to get people out of compression stockings. I want people with leg ulcers to get back to having no leg ulcers. I want to prevent leg ulcers. I want to prevent things. I don't want people to wear them. Now, there are exceptions, of course. If you're injured or if you're going to be in bed for a long time, you can get a DVT. So if your mobility changes, if you are unable to walk for any other reason, pain, if you're going on flights, any flight over 4 hours, you must wear compression. And 2 to 4 hours we're not really certain of, but definitely over 4 hours. So there's certain instances where we know that compression is good, but if you're normally fit and healthy, got no symptoms, I would never recommend them. I just sort of say if they're more comfortable to wear them, but they don't prevent veins coming, they don't treat anything. The only time I use them is as part of a treatment. So in other words, if you have sclerotherapy, then you have to hold that vein shut so you don't get clots in the vein as it's working. Sclerotherapy does not glue the vein shut, it kills the vein wall and you have to empty it, and it's the only way we know to do it. With endovenous laser, the heat treatments that are inside the veins, you're actually shriveling the vein and you're closing at the same time, so you don't need them. So we just put them on to help with bruising if you had phlebectomy. So it's always about the science of what you're trying to achieve. And interestingly, I mean, I don't want to get boring, but you can get really boring about compression because when you wear compression stockings, they actually have no effect at all on your deep veins, but they actually only affect your superficial veins. So you will see some surgeons who sort of say you don't need to wear them after foam sclerotherapy, but they don't understand that in fact they're talking about foam sclerotherapy in the venous veins as an alternative surgery where it doesn't have an effect, but also foam doesn't work in it, so they should be doing that in any case. So quite often you hear people who don't truly understand the different layers of veins and the new ideas we've got in the anatomy will say, after foam, you don't need compression, it makes no difference. What they're talking about is a different layer of sclerotherapy. But just as a general rule, if fit and healthy, don't know about it.
And flying over 4 hours, I didn't know that.
Oh yeah,
That's scary, yeah.
There's some very good research. In fact, if you all want to get really, really scared, there's a research
Thanks.
study. Yeah,
Just went on positive.
there's a research study that goes shows that if you look at people getting off a 7-hour flight or more, 1 in 12 have a DVT. So you think that, so a jumbo jet is loading of how many, but that's 300 people, and most of those people go home and they'll say, oh, you know, I hate this flight because my ankle swells a bit at the flight. Not that one, but that one. And they're having small DVTs, but the thing with DVTs is if they're below the knee, they don't tend to have long-term problems. If you look at people in hospital who are just lying there for just flu or things like that, there's been research showing that 83% have DVTs that are undiagnosed. But it depends which technique you're using, because if you use radioiodine and you look at the tiny, tiny clots, of course 83% have them. But if you look at the ones that are going to kill you, of course it's nowhere near that number. So we really need a different name to stop frightening people for ones that are there but inconsequential versus those that are at the knee above that might kill you or might cause a long-term problem. We've tried to bring some other names. We actually call them DTT and DVT, but it didn't take off, so back to the drawing board.
Take off. I mean, you need to do a campaign with all the airlines. I feel like that should be plastered across all the backs of the, so are you wearing your compression stockings? Are you on a flight for more than 4 hours? That would be helpful, wouldn't it? Are there any other questions? Yes, this one.
I don't want to flip-flop, thank you to everyone, that was really articulate. But I had a question for Mark on pelvic congestion, because I hadn't heard of it before. I just wondered what the primary causes were, sort of how it manifests and what the challenges were in diagnosing it.
Yeah, I've got a lovely book that you need, so if you give me your address afterwards, I'll send you one. So pelvic congestion, the trouble with pelvic congestion, about 1.5 million women have it in the UK, and unfortunately also that number of men, because it causes hemorrhoids, it causes varicose. So if you've got sons, they used to have the thing called the medical, which we all hated as boys. They don't do it now because of all the different reasons that we have. And you used to go in front of a doctor at age 11 and you used to have to turn your head to the left and cough. They would check 2 testicles, no hernias, but they also checked no veins around your testicle. So all those boys had this varicose vein removed. For every boy who's got that, there's a woman who's got the same thing around her ovary, but because it's inside, when they then start reaching menarche or they're young, they start saying, I've got this ache and I've got the pain. Oh, it's women, you know, that's just, you've got to put up with it. And because you can't see it, doctors are terrible if they can't see something. So if you stand up, you've got varicose veins on your calf, you've got varicose veins. You haven't got varicose veins on your calf, you don't have varicose veins. You have, but we don't diagnose it. It's even worse in the pelvis. So but the simple way to think of pelvic congestion syndrome is varicose veins of the pelvis. And it basically, in my book, and I've just written, because I give this lecture everywhere, I just draw a very simple line with a foot at one end and a heart at the other end, and I draw a line halfway up, and I say the blood has to get from your toe to your heart. Very simple, that's what veins do. If it falls out behind your knee, it's called small venous vein reflux. If it falls out of your groin, it's great venous vein reflux. If it falls out anywhere else, it's perforated reflux. And doctors will tell you all this, and they'll go on. Anywhere above that line doesn't exist. But take away the emotional side of it's deep inside, it's flipping obvious. That's why you get ovarian vein reflux, you get pelvic vein reflux, and of course, so women, as I said, hemorrhoids, vulval varicose veins, vaginal varicose veins, those are the ones you see, and then all the symptoms I said before. But men, prostatitis, erectile dysfunction, Viagra works because people who've got veins are leaking, so they get the blood into the penis for the erection, but it falls back out because they've got pelvic congestion. So instead of having Viagra, if they put a coil in those veins, they wouldn't need the Viagra. And there's a man, one of my very good friends, Wad Shiram, who's a surgeon in Singapore, has been going around the world actually showing that you can do a local anaesthetic operation. These men, you can put a tiny local anaesthetic here on the dorsal of the penis, put a catheter up, a blob of super glue, cyanoacrylate, and you can actually close it. And we've got this real problem, and I'm giving, as I said, I'm giving a lecture tomorrow, the day after in Georgia, in Tbilisi, and one of the things I'm debating is I've got to say what the problems are pelvic congestion syndrome, and I've been trying to think about it on the way up here because I was stuck on the train, and basically the problems are, number one, the public don't know about it, number two, no doctors know about it, and number three, the doctors who do know about it haven't studied it and mistreating people. They're using MRI and CT because this is logic that it's deep inside. They don't show you anything because you're lying flat. You don't see varicose veins when you lie flat. So there's so much education that's needed, and the public need to know about it. And as I say, about 1 million women in the UK are suffering, and we're only just starting to realise the men who get pelvic congestion syndrome as well. And it's just, you know, if ever you hear someone talk about pelvic congestion, they say it's a problem of fertile women. You walk out there 20 years out of date. It affects young women who've never had children, women of childbearing age, postmenopausal women, and men of the same ages. And it's just varicose veins in the pelvis.
And it's really interesting, actually, the scan that you do for that, isn't it? Don't you have to sort of lift people up slightly?
Yeah,
because, like you said, they disappear when you're lying down.
So you never ever want to look for veins at all when you're lying flat, because you can't see them, obviously. So what we do is we do a transvaginal duplex, because obviously you can get in and see the veins there. Now, if people don't want or can't have transvaginal, you can do it transabdominally, but it's more difficult. The gold standard test was invented by a colleague of mine called Judy Holdstock. It's called worldwide. It's called the Holdstock-Harrison Protocol, invented at the Whiteley Clinic. And you put the lady at 45 degrees so that the blood will go back to the heart if you stimulate it. But if the valves are working, it won't fall back down. But if they've got pelvic congestion, it falls back down. The duplex ultrasound shows that. So what you can do is you get them to do what's called a Valsalva. So they go and strain, and if the valves are shut, you don't see reflux. And you do what's called a Kegel squeeze. So you clench your buttocks, and that forces the blood up to your heart, and then you let go, and the blood, if you've got pelvic congestion, you just see it go back down into the pelvis. If you don't have pelvic congestion, you don't see it. So the tests are there to be done, but unfortunately what happens is you go to doctors who've seen our research and they don't have a duplex and they don't have someone skilled to do it. So they give you an MRI, and then they give you laparoscopy and stuff, and they don't see it because you're lying flat.
Mm-hmm.
And there's so many simple things in medicine that people don't think about, because doctors do what they like to think. It's the old thing of Abraham Maslow: if you only have a hammer, the whole world looks like a nail. So they will do what they've got around, rather than saying, what does this person in front of me need? And if I can't do it, they're too arrogant to send them to someone who can do it, or get the people into their unit that can do it. And I'm constantly fighting this on leg ulcers, pelvic congestion, all the things that I get just so annoyed that doctors don't have that ability to say, oh, this isn't my speciality, I know all this, or go and learn how to do it.
I think we need to see more of a movement towards that, and each of you are such super specialists in the areas that you address, but actually I think that's what the public need, to really understand the importance of seeing a specialist.
Yeah.
And not, look, obviously the first step is often your GP, but I think you're right, sometimes people fall short there because they don't get the answers, and we need the education to know who are the exact people that we need to see for these very complex, conditions sometimes.
And the worst thing is, it's the current thing, if you go on the internet about any condition at all these clinics that say free consultation or come to us and we only charge this, instantly, if they're talking about money rather than what's wrong with you, have red flags, because they've got private equity backing and they're only thinking of that. What you need pathologically interested people doing leading it for the talk.
Yeah, 100%. Are there any other questions?
So I have a question for Ms. Laura. So in Asia, we have these two surgery that we love the most, which are cheekbone reduction and also fat transfer. I know they're really good, but for cheekbone reduction, most of the clients, the result will cause them sagging skin. Is there any way to prevent?
So what it's doing is the bone is the underlying support that everything else is hinging on, and it's a bit it's not quite like for like, but we were talking about aging changes where the bone gets smaller. Well, this is again making the bone smaller. So the bone is supporting the skin and lifting it out. And if you make it smaller, then the tissue that was holding out can drop quicker. It may not drop immediately if you have that sort of surgery when you're younger, but as you age, there's less support than you would have had you not reduced whatever bone, whether it was cheek, chin. You basically remove support from it. It's difficult to absolutely prevent it without building up the area again, because the natural instinct to treat that is to replace what was removed or what has absorbed, but that defeats the purpose of the original surgery. So it's really then about not doing it to extreme. You have to accept a compromise in the early result when you're young so that you don't age badly when you're older, and then about keeping the rest of your tissues in as good a condition as possible so that you don't contribute something else to the inevitable effect of the first surgery. Does that make sense?
Yeah.
For fat transfer, the key thing is being at a steady weight, particularly if you have it done when you're young, because you are transferring that fat from somewhere else in your body. It can be knees, it can be inner arm, it can be tummy, it can be hips, it varies. And you have to wait about 6 to 8 weeks to know how much of that fat you keep. But what you keep it more or less permanently. It will age with you, but it can, just like any fat anywhere else, it can get bigger or smaller if you gain or lose weight. And it's a big issue in the face if someone gains weight after fat transfer. It doesn't happen often, but if the fat becomes enlarged because of weight gain, remember if you say you took it from a tummy and you put it in the face, and your weight pattern of gain is to gain on your tummy, then even though it's a small amount of fat, it gains proportionally more than the fat in your face. So the key thing is a steady weight. This obviously doesn't happen everyone, but if it does happen, it's quite difficult to treat. If you lose a lot of weight, the fat cell shrinks, so you also lose the effect of the added volume. So the key thing is a steady weight, and it's particularly if you have fat transfer at a young age, because you change more over your lifetime some people change more than others. You know, I have some patients who are the same weight as they were when they were 20. I have other people who are vastly different, both up and down, from when they were 20, when they were 30, when they were 40. Pregnancies, hormones, weight gain, just life. So some people do not change much, but other people change a lot, and you don't know at 20 which category you fall into. You know, you don't know, you've only been, you don't know whether, you know, if you're female, you don't know how pregnancy will change you, you don't know how menopause will change you. Male or female, you don't know if you'll gain or lose weight, you don't know what your lifestyle, will you exercise as much, life changes. Some people don't change much, other people change a lot. So it's, again, none of these things are bad things, but you have to think of the long game, not just the immediate result.
I think that those are very wise words. Thank you for the question. Are there any more questions?
I'm not against fat transfer or non-surgical treatments.
Caveat.
They all have a place, but you have to look at the long game, not just the 3-month result. You have to think of the long term.
Always. Yeah. Any more questions? One more here.
Yes, I have a question for Harry about this balance board you mentioned, this health ball. Are there any specific brands or any of them is good? How many minutes a day it's important to do exercises, and is it suitable for kids from what age they can join and do it?
Any age is fine. How long each day? I mean, a couple of times a day is pretty good. The other equipment that you would look at besides the wobble board would be a Swiss ball, those big inflatable balls, a foam roller that you can roll on, probably an elasticated support belt for when you do get those acute episodes, and a hot and cold compact would be just to have at hand to apply to the area.
Your whole support kit sounds like SOS kit, so you don't have to see Garry. I think that's probably time for all of the questions, but I know all of the speakers will be around if you do want to chat to them for a little bit longer, maybe on a one-to-one basis. But firstly, from me, a very big thank you to all three of you for your expertise and your brilliance, and for, just blowing our minds with all of your amazing knowledge. So thank you for being here. Thank you very much. And a big thank you to the Lanesborough as always for hosting us so beautifully. It really is our favourite venue, I promise. Shouldn't say that with the other events, isn't it? And then to everyone here, a really big thank you for joining us. We always love having you here, and if you'd like to come to any more of our events, just make sure that you've registered on our website, thebeautytriangle.com. You'll be the first to find out about what's happening in London, and now excitingly in Dubai as well. We've just launched some events over there. So don't forget your goodie bags, don't forget to leave your referral cards if you'd like us to connect you with anyone, and thank you, and I hope to see you all again.